Welcome to Christian Leadership Institute of Minnesota and beyond, KITENGELA campus here in Kenya, the School of Psychological Counseling. Today we are going to study about abnormal psychology. Abnormal psychology. And to begin with, I want to say that the etiology of abnormal psychology, or the study of mental disorders, is multifaceted and often involves a combination of biological factors, physiological factors, environmental factors, social and cultural factors, just to mention but a few. So now to expound on it is that we have biological factors, and this includes genetic predisposition. These are the things that we inherit from our forefathers, the things that you get or you inherit from your fathers when they passed it on, when they passed it down to you when you were being born. We also have neurochemical imbalances in the biological factors. And these are the factors that comes in when you are being born. They are things that, the chemicals that composes the human nature, the ones that makes you to be what you are. We also have brain structure and function abnormalities and hormonal influences. A human being is normally influenced by hormones. It is usually said that we are products of hormones. That's why you find that especially when you go to the female gender, you find that there are times when their hormones are high, there are times when they are low, and all this comes about by different changes in the way they relate to the environment. We also have, as we say, that genetic factors which can contribute to the likelihood of developing certain mental disorders. That is when we say that there are things that we can inherit from our parents, from our forefathers, and maybe from the tree that you came from, there were some abnormalities, and you find those abnormalities following you all through. We said also that neurochemical imbalances, such as disruptions in neurotransmitter levels, can affect mood, cognition, and behavior. Then we go to the second factors, which is psychological factors. This encompasses individual personality traits. These are those that when people look at you, they say this one is outgoing, this one is not outgoing. Or they say that this one is hyper, this one is just reserved. So you find the personality traits. We are born different, we have different personalities, and we behave according to those personalities. We also have coping mechanisms, cognitive biases, and learned behaviors. Traumatic experiences, unresolved conflicts, and maladaptive thought patterns can contribute to the development or exacerbation of mental disorders. Then the third factors we have here is environmental factors, and these include early life experiences. It is the way we were brought up and from the environment that we were brought up, such as childhood trauma or adverse events. Maybe as you were growing up, you were exposed to certain adverse events, or you faced several unjustifiable means, or you found yourself in a traumatic experience when you were being born up, or being grown up, when you were growing up. For example, in the Bible, we have this man when David wanted to go and show kindness to the family of Saul, as he had promised Benjamin. He went to a place and he was looking for someone whom to show mercy, and he was told that there is this one particular person who had been there, but when the child was growing up, there came war within the environment. And in the Bible it is written that the maid that was taking care of this child ran away with the child. And on that aspect of running away for their life, they fell down and the child broke both of his feet, and the child grew up to be someone who was lame on both of his feet. And the child grew up just like that. So you find that there are things, there are events or traumatic events that maybe you were exposed into while you were growing up, and this comes about into your life. As well as ongoing stressors, social support networks, socio-economic status, and cultural influences. We have seen in places where the area has been struck by an adverse drought, and the children are growing up in those areas, and when you look at them, there are certain behaviors that come out of that situation which may make this person to behave in certain ways. We also have cultural influences, which also influences a person. We are products of culture. We come from different areas, from different cultural backgrounds, and in those cultural backgrounds, there are things that we are told that you are not supposed to do this, these are what you're supposed to do, and you find those influences comes into our growing up. Then the environmental stressors can interact with genetic vulnerabilities to increase the risk of mental health problems. And the last factor we are going to look at is social and cultural factors. Societal attitudes towards mental illness, stigma, access to mental health services, and cultural norms regarding acceptable behavior and emotional expression can impact the prevalence, manifestation, and treatment of mental disorders. You find that in our cultures, when someone is perceived to be mentally ill, they have that stigmatization name where they call these people, especially here in Kenya, they nickname this person or they put names on them and they call them cheesy. Uyo ni cheesy. And they see no need of taking this person to the hospital simply because the person is sick or is behaving abnormally. I want to say that there are certain abnormalities that if treated early, if known early and the interventions are done early enough, an individual can come back to normalcy. But the problem is the way the society perceives such issues in them. So general symptoms of abnormal psychology, which encompasses a wide range of mental disorders, can include 1. Changes in mood. Persistent feelings of sadness. When you find that somebody changes all of a sudden, their mood changes abruptly. I don't know whether you've gone to an office and you are told that the boss today did not wake up well, so you go and come back later because of the mood that the boss is having. Or you are with your spouse and there are certain mood that they behave in certain circumstances, and then you look at them. That's why we said in counseling when we were beginning this course, we say that you don't look at the problem of people and then you try to probe in before they come unto you. When you see them having some issues, that let them walk through their issues, and then when they feel it is okay to talk about it, let them talk about it. So you find that at times there is that persistent feelings of sadness. Somebody is sad for no apparent reason. They are just sad and they are gloomy, they don't want to talk to anybody, and they are basically sad. And others may tell you that I don't know why I'm feeling the way I'm feeling. There is that hopelessness that comes in them because of certain situations. They find that there is no hope in life. Irritability or mood swings that affect daily functioning. All this that we are saying is that which, when it comes, it affects the daily functioning of this individual. You've known this person to be behaving like this and like that, and then all of a sudden they change for no apparent reason and they become somebody totally different from the ones you knew. Then number 2 is anxiety and fear. This is excessive worry, fear. You find that there is an excessive worry. Somebody is fearing for their lives, is fearing for no reason, is looking here and there, like somebody is chasing them. Or anxiety that interferes with normal activities or relationships. So you can find that Certain anxieties may come and interfere even with normal relationships. It makes this person not to relate well with others. The third issue here is cognitive disturbances. When we talk of cognitive, we're talking of the mind. We are talking of the mind. Difficulty concentrating. This person cannot concentrate on anything. They are taking this and leaving it half done, taking another one, and they never finish anything. They are just there and they can't concentrate. Racing thoughts. They have a racing thoughts. They think a lot. They think back and forth, back and forth. Memory problems. You tell them this one and they forget all of a sudden quickly. They forget everything. Or impaired decision making. They cannot make decision on the way it is supposed to be done. You tell somebody something or you ask them a question, and the kind of a decision that they make, you wonder what could be happening to that individual. Then we have distorted perception. Distorted perception. Here is where there are two issues here, two extremes, either hallucinations or delusions. Hallucinations is seeing and hearing things that aren't there, things that are not there. They are hearing things, they are seeing things. You are with somebody, but they are seeing things. They are laughing, or they are crying, or they are fearing for their lives. It's like they are hiding from something that is being thrown at them. And when you look at those things, there is nothing. They fear, they see things that people do not see. Or delusions is where this particular individual have false belief system which are not based on reality. They just believe on something that is not there, something that has got no reason, it has got no root, but it is false beliefs which is not based on reality. And the fifth issue here is changes in behavior. Changes in behavior, we are talking like social withdrawing from the social groups. If somebody all of a sudden starts staying alone, they don't go to parties as they used to be, they don't go to their groups as they used to be, they just withdraw themselves, they just isolate themselves and they stay indoors, or they put themselves in a place where nobody can meet them. Changes in sleep patterns, you find there may be insomnia or hypersomnia, where somebody either oversleeps or relax sleeps in totality. Appetite changes, that is eating too much or eating disorders. When we talk of eating too much or eating too little, we are talking of conditions like anorexia nervosa, bulimia nervosa, or we are also talking of binge eating disorders, where this person can decide to eat a lot of food, or they can decide to eat very little food, or this person might eat a lot of food and then they go to look for ways on how to remove this food again from their bodies. That's why you find somebody eating a lot of junk and then they go to a gym. Well, after coming from the gym, they come and eat a very big plate again and then they go to a gym. So it's all this is a disorder. There is the agitation or restlessness. This person is not restful. He or she doesn't have that comfortability. Then we have substance abuse. This is where somebody engages themselves in drugs, increased use of drugs, alcohol, or other substances as a coping mechanism. So you find that the life of somebody has become totally unmanageable, and now they think that the only way is to engage in drugs so as to lock or to unlock their mind so as to function in the normal way. That's why you find those people who are adverse users of drugs and substances. Every time they say, I want to go and remove the lock, so they can't stay without those drugs. They are using drugs as a means of coping mechanism. And it has been said that especially those children who, when growing up, they find themselves suckling. Maybe you remember the developmental stages where we say that there is the phallic, the anal. You find that the child was still sucking and he remains in that condition. Maybe there was over a gravitation, and this child remained in that condition. So when they grow up, they feel like suckling, and that's why you find themselves looking for something to smoke. And it has been said that many of the people, majority of those people who smoke, is because in that stage where they were supposed to be sucking, maybe they oversucked, or maybe they undersucked, and therefore they are looking for something to put into their mouth in which where they find themselves smoking. So increased use of alcohol, drugs, or other substances as a coping mechanism. Then we have the physical symptoms. Physical symptoms here, we are talking of unexplained physical ailments or complaints without medical cause. These are the psychosomatic symptoms where somebody complains a lot, and when they go to the hospital, there is nothing that is found in them, but they feel that they are unwell, they feel that their body has some issues. Then we have impaired functioning. Impaired functioning is like difficulty functioning at work or at school or in a relationships due to mental health symptoms. Here is where somebody has certain symptoms and therefore they cannot function well, even in relationship. They cannot relate, they can't contain relationships, they can't work well in the places of work, even in school. They lack that concentration and they cannot concentrate on what is being done. Then we have risk-taking behavior. You find these individuals engaging themselves in behaviors that are risk-taking, like engaging in risky behaviors such as reckless driving quickly, driving too fast without minding the lives of others and their lives, without minding, they don't even care on what could be happening. Then there is that self-harm where a particular person want to harm themselves anyhowly. I don't know whether you've seen someone who is over angry, and then when they are angered, they throw themselves down, they throw themselves even on the fire, or they take something and they hurt themselves. Or suicidal ideation. You find somebody every time they are thinking on committing suicide. That is a term called suicidal ideation. Then we have interpersonal problems. When we talk of we are talking of somebody with other people, difficulty maintaining relationships, conflicts with others. Wherever they go, every place they are, there must be conflict with the environment, with the people that they relate with, or difficulty trusting others. They get that hard time in trusting other people, and they feel that the only people to trust is only themselves and nobody else. In counseling, individuals with abnormal psychology concerns, several general issues often arises. The people with abnormal psychology concerns, they have several issues which often arises, like 1, stigma and self-identity. Helping clients cope with societal stigma surrounding mental illnesses and supporting them in developing a positive self-identity despite their condition. So you as a counselor, you are supposed to help this person to identify themselves. You are supposed to help them to have that self-identity, to know themselves, know who they are. Let them know themselves, let them know who they are, let them know the potential that is in them. Help them to come up with mechanism on how to deal with issues. Let them make the SMART goals. Let them sit down and do the SWOT analysis and try to come up to a position where they no longer concentrate on the stigma, on how people think about them. Then we have system management, symptom management. In symptom management, that is providing strategies to cope with and manage distressing symptoms such as anxiety, depression, or psychosis in daily life. You help them, you provide strategies to them on how to cope with and manage these distressing issues or symptoms which emerges from their lives. Then we have medication management. In medication management is collaborating psychiatrists, psychiatrists or other healthcare providers to monitor medication effectiveness, side effects, and adherence. When you find these individuals are behaving in a particular manner and their issues is more on medication, try to help them to get that to get that awareness on how to manage themselves, on how to be dealt with, and if it is the effect of the drugs that they are taking, take them to the hospital where they can be managed, or where there can be a change of those medications so that they can function well. Then we have crisis intervention, addressing immediate crisis such as suicidal ideation. You try to address those issues. When this person is having that self-harm, try to bring them to their common sense, try them to understand that there is no need of harming themselves, and even if they harm themselves, it is them who will need also to help themselves again to come back to normal. Of psychotic episodes, and providing appropriate interventions and referrals for acute care if needed. When you find that this individual requires an acute care, then you need to help them to get that intervention. Then psychoeducation, educating clients and their families about the nature of their conditions, treatment options, and strategies to self-care and symptom management. You may find maybe this person is having is in a condition where maybe the family members doesn't know even how to deal with this issue, with this individual. Try to help them to get that attention, to get that help on how, or that self-care on how to manage this person, so that when they will be with these particular individuals in their homes, they know how to care for them. Then cognitive restructuring, helping clients identify and challenge maladaptive thought patterns and beliefs contributing to their symptoms. You help them identify and challenge those maladaptive ideas, those maladaptive thoughts that comes out of them. When you talk of maladaptive, we are talking of things that are abnormal according to the normal functioning or the norms within. We all come from a place where there are certain norms that are required to be done, and when you find that somebody is behaving in an opposite direction, in a weird behavior, that's when we talk of maladaptive behavior. Emotional regulation. Here is teaching skills to identify and regulate emotions effectively, including mindfulness techniques and stress management strategies. When you talk of mindfulness techniques, is where you are taking these individuals to a meditation, to do some meditation on themselves, to sit down and try to look deep into themselves, to sense their life, their in being. This is where you come up with mindfulness techniques like radio technique, where they try to tune into different channels and then they concentrate on a particular channel on their lives. Or you try to take them to tell them to go, maybe to assume that they have gone to a space, and then they try to grasp something in the space that is good in them, or that gives them that pleasure. So you try to help this individual to look at the other side of life. You try to tell them that in life there are two sides. There's the bright side, like the hand here, and there's the dark side, and you tell them not to look at the dark side, and the dark side are the things that are passed on, the things of the former life, and try to concentrate on the future, on the things the brighter things in life. So those are mindfulness techniques that you can help these individuals to help them address their issues. Then we have social skills training, providing guidance on developing and maintaining healthy relationships, communication skills, and assertiveness training. This is a vice that is so much required. Then we have behavioral interventions, implementing behavioral techniques such as exposure. When this person lacks certain things in their lives, maybe they did not maybe got certain exposure in life, you help them get that exposure so that they can make their minds well and structured in good manner. So you find that behavioral techniques such as exposure therapy for anxiety disorders or behavioral activation for depression. Then we have family dynamics, addressing family conflicts. Different families have different dynamics. Different families have different conflicts. Different families have different issues that they face. So you help this particular individual to address those family conflicts that arises, the functional communication patterns, and the impact of the client's condition on family relationships. Then relapse prevention. There are those who have gone on the preventive measures and it's like they are relapsing. So you developing strategies to prevent relapse and maintain progress achieved in counseling, including identifying triggers and developing coping skills. Then we have cultural sensitivity. Recognizing and respecting cultural differences in attitudes towards mental health and adapting counseling approaches to be culturally sensitive and relevant. So when you find that an individual is deviating from the cultural norms that they come from or where individuals are, you help them recognize and respect those differences in attitudes towards their mental health and helping them getting those adapting approaches, counseling approaches to be culturally sensitive and to be relevant. Then we have abnormal psychology. That is what now we are coming down to say that abnormal psychology employs various approaches in mental health treatment tailored to the specific needs of individuals and the nature of their disorders. Different individuals have different issues, and in abnormal psychology is where there are tailor-made strategies on how to help these individuals to cope with their disorders. Some common approaches include, but not least, 1, psychodynamic approach. Psychodynamic approach, which is rooted in Freudian theory, and this approach focuses on exploring unconscious conflicts and unresolved childhood experiences that contributes to psychological distress. This is where Freudian approach, or psychodynamic approach by Freudian theory, it states that there are things that are in subconscious mind that which comes up sometimes and they have this effect on an individual, and therefore you go down there to the childhood experiences and you try to look at the unresolved experiences that were there in them, the things, the issues that they had, and it was never resolved as this person was growing up. So you try to get there and to help them. Techniques such as free association, dream analysis, and exploring transference are used to gain insight and facilitate healing. The second approach that can be used here is cognitive behavioral approach, or CBT. This approach emphasizes the interplay between thoughts, emotions, and behaviors. CBT aims at identifying and modifying dysfunctional thought patterns and behaviors through techniques such as cognitive restructuring, behavioral experiments, and exposure therapy. Then the third category, or the third theory that can be used here, is humanistic existential approach. Humanistic existential approach, such as person-centered therapy developed by Carl Rogers, emphasize empathy and conditional positive regard and genuineness in the therapeutic relationship. Now, this is so much on the side of the counselor, where you employ these techniques, you employ these skills of unconditional positive regard in these individuals, or empathy, so as to get to understand this individual. Existential approaches focuses on exploring issues related to meaning, freedom, and personal responsibilities. And these approaches aims to facilitate self-awareness, personal growth, and self-actualization. Then we have biological approach. This approach focuses on biological factors underlying mental disorders, including genetics, neurochemistry, and brain structure or brain function. Treatment options may include medication management, neurofeedback, and brain stimulation techniques such as electroconvulsive therapy, ECT, or transcranial magnetic stimulation, TMS. Then we have sociocultural approach. Sociocultural approach. This approach considers the influence of social, cultural factors on mental health. So it examines how factors such as socioeconomic status, cultural norms, discrimination, and impact So we see that this examines how factors such as socioeconomic status, cultural norms, discrimination, and access to resources impact the development and expression of mental disorders. So culturally sensitive interventions, community-based programs, and advocacy efforts are often emphasized. Then we have integrative approach. In the integrative approach, many therapists adopt an integrative approach that combines elements of multiple theoretical orientations to address the complexity of mental health issues. This is where a therapist employs various techniques, various theories in order to fix or to fit to these particular issues of this individual in order to help them to come back to their senses or to address their mental health issues that they are going through. This may involve integrating techniques from different approaches to create a personalized treatment plan tailored to the individual's needs and preferences. Let's now look at definitions and overview abnormal psychology. Abnormality can be understood from the following criteria. 1. Norm violation. Every society has a set of rules that forms the basis for deciding what is right or wrong, where, when, and with whom to do what, e.g., when, where, what, and with whom to eat with, when and whom to marry. Every society comes up with their ways of living. Like you find that in some African cultures, you find that there are certain duties that have been preserved for certain people. Like for example, you find that doing the works of the kitchen, like cooking and washing clothes and washing dishes, it has been reserved for women. And when you find a man going against that norm and they do those things, there is the way the culture or the people of that culture perceive this person to be abnormal. And there are things that are supposed to be done by men in that culture, and when you find women doing those things, they are perceived to be abnormal, like something is going on which is very wrong and is supposed to be like that. Norms vary across cultures, and therefore they are a weak basis of labeling one as abnormal. In that community, in that society, this person can be perceived as abnormal, but when you go across other cultures, when you get that awareness or when you get exposed to other cultures, you will find that what is perceived to be abnormal in this culture may be normal in some other cultures. For example, there's a time that I went to Turkana here in Kenya, and in those places is where people don't regard clothing as such, and when they see someone putting on clothes, they believe that you have been indoctrinated by the Western culture, or you have been westernized. And so as I went there, being a guest in the place that I had been invited, according to their norms, is that when a guest comes, there are those young girls who are still maturing. the teen girls from 19 years and below, those who have not been married and they are still young virgins. What happens is that those people do not put on clothes. So there are those braces that they put on their chest, the braces they put on their chest, and they have just some rings that they put across their that they put in the stomach, around the stomach, and then they only have those clothings, not clothing per se, but covering that covers just at the front and the back alone. And these girls comes to serve the guests who have come, and they come in 4 of them, that is 2 pairs, and they come bringing food, and they kneel down as they give this, as they serve you. And when they are doing that, the chest is bare, is open, and according to them, that is very normal. So to me, it looked like abnormal. What was happening? What did these people mean? What were they trying to show me? So you find what is normal in this place could be abnormal in some other place, or what is perceived to be abnormal here, that is not the best way to label someone as abnormal based on culture, because cultures varies across board. Then the second here is statistical distribution. Statistically abnormally reflects any substantial deviation from statistically calculated average. Individuals whose behavior deviates from the majority are regarded as abnormal. It may apply in some evaluation of psychological abnormality. The concept of mental retardation tends to reflect this criterion, because those who are considered mentally retarded score below average in intelligence tests. In this context, the very intelligent or geniuses may be considered abnormal. This is where somebody score above average every time, or they score below average every time, and they are perceived to be abnormal. This is where they do the statistical method where they want to test the abnormality. Unfortunately, this criterion ignores values, for example, desirable versus undesirable behaviors. It considers the average behavior as ideal and ignores the extreme and positive characteristics such as geniuses. They do not regard those ones. Then we have personal discomfort. This criterion considers those who are not comfortable with their lives and considers them abnormal, i.e., those who tend to seek treatment. In this case, those people tend to judge their own state as normal or abnormal. There are people who have stayed in certain conditions, and let's say, for example, it's a girl who have come up to an age where they think that it is time to be married, but no one comes to approach them, and then they come to a point where they believe that they are abnormal since nobody is approaching them. And this is the greatest issue that is happening with self-identity. And you find this particular individual trying to dress in a particular way, in a manner as to trying to attract men so that they may look on them. And this is where you find people going to extreme, where they expose themselves, they put on very small clothing in them so that some parts may be visible in the urge that they may be noticed. Or you find somebody doing certain things in order to attract that attention, but you find that it is them who seems to consider themselves as abnormal or normal. In this case, those people tend to judge their own state as normal or abnormal. This approach is probably the most widely used in the case of the less severe psychological disorders. Such people go for therapy not because other people have declared them abnormal, but because they are unable to cope with their way of life. So you find it is them who have judged themselves harshly like that, and they go for therapy because they believe that they have some abnormalities in them. Then we have maladaptive behavior. The level of maladaptiveness determines one's abnormality. For instance, Does the individual's behavior pattern meet the demands of his or her life, such as, can she or he hold a job? Does he or she have a spouse? Is he able to relate to others well? Can they pay bills on time? This criterion overlaps with the norm violation criterion because many norms help us to adapt to society requirements. It may be related to personal discomfort because the consequences of our behavior may make us feel uncomfortable and therefore seek help. For instance, a person who cannot hold a job due to continuous drinking may want to find a solution to his drinking. This is where somebody finds that their behavior has become unbecoming and therefore they need to go and seek for help in order for them to maintain a normal life strategies or life management as others. So a maladaptive approach tends to concentrate on the practical pattern of getting through life with some measures of success. Inability to cope with the demands of life implies a requirement of psychological help. Now, the deviation from ideal. An individual who has failed to achieve certain ideals may be considered as maladjusted, e.g., an individual may fail to hold a job. Someone is being employed today, and the other day they are sacked from that job because of their behavior. Have a family or an intimate relationship. There are those people who cannot maintain a relationship. They cannot live with their families. There are those people who keeps on fighting and chasing each other, and they can't contain their children and their wives and their husband. They cannot stay together. They can't maintain that relationship. They can't maintain that intimate relationship. However, this may be closely related to the norm violation and therefore changes as the society ideal change, e.g., in developed countries having children is no longer an issue. You find that in the Western countries, to them now having children is not a big issue. People just come together as a contract and they say that we are going to stay together for 5 years contract and we are not going to have any children, or we are going to have only one child. So you find them, this is where people come together, they don't want any commitment. It is like the present generation where you find that the young men and girls, they just want a man or a boy to be with them, to help them with bills, but they don't want to be committed at all. So this is behavior that is deviant, maladaptive, or personal distressful. We have neurodevelopmental disorders. Neurodevelopmental disorders are conditions that affect the development of the nervous system, typically in early childhood. They include autism spectrum disorder, ASD, attention deficit or hyperactivity disorder, ADHD, intellectual disability, and specific learning disorders. Each disorder has its own unique characteristics and challenges, but they often involve difficulties with communication, social interaction, and cognitive functioning. Early diagnosis and interventions are crucial for managing these disorders and improving quality of life. Autism spectrum disorder, ASD, is a complex neurodevelopmental condition characterized by challenges within social communication and interaction, as well as restricted and repetitive behaviors or interests. It's called a spectrum disorder because it affects individuals differently and to varying degrees. Some may have mild symptoms and life independence, while others may have significant impairment and require lifelong support. And it's very unfortunate that you find some parents, when they realize that their child is having such conditions, instead of letting this child to interact with other children normally, they hide them, they put them under key and lock, and they don't want this child to get out because of the stigma that they may feel. But the good one thing that we want to tell people is that once you find that a child is in this condition, just do not keep them. Let them socialize with other children. Let them walk out their own lives with others, and with time they will come to realize that it is their conditions that they came up with, and they will accept to live with it. But when ukiwa unamficha huyu mtoto, hutaki atokezee kwa watu wengine, huyu mtoto unamfanyia makosa. Autism spectrum disorder, or ASD, is diagnosed based on behavioral criteria typically observed in early childhood. Early interventions such as behavioral therapy and educational support can significantly improve outcomes for individuals with ASD, helping them to develop skills and cope with challenges. Understanding and acceptance are crucial for supporting individuals with ASD and promoting their well-being. This child, just don't keep them. Take them to school, take them to early treatment. Actually, it has been said that if they are taken, if it is recognized early, and they can be treated, and interventions can be done on their lives as early as it is being detected, and it might improve their life adversely. ADHD, or attention deficit hyperactivity disorder, is a neurodevelopmental disorder characterized by symptoms of intention, hyperactivity, and impulsivity that interfere with daily functioning and development. It is one of the most common childhood disorders, but can persist into adulthood for many individuals. People with ADHD may have difficulty sustaining attention, organizing tasks, staying focused, and controlling impulses. Treatment often involves a combination of medication, behavioral therapy, and lifestyle changes. With proper management, individuals with ADHD can learn to cope with their symptoms and lead fulfilling lives. Now, let's look at mood disorders. Mood disorders. This is where we are talking of changes in mood from time to time, which is actually abnormal, which may affect the people around. It is normal to feel low or high depending on the environmental stimuli. It is very normal to feel high. It is very normal to feel low, depending on where you are and the kind of environment that you are in. It also depends on the situations that you come in. This reflects effective manifestations of our experiences. However, when such situations become severe and prolonged, it calls for concern, and it is considered mood disorders. Yes, it is very normal to change sometimes. It is very normal at times to feel not to want to associate with people simply because of them or their behavior, or simply because of how you relate with them, or simply because of the happenings that are going through. But when it keeps on persisting, when you see everybody and it's like you don't want to see anybody within your sight, you don't want to talk to anybody, you don't want even to be greeted, you cannot even accept a greeting from people, you are doing things alone, and you are putting some behaviors that reflect the normal functioning, then it is considered mood disorders. Let's look at types of mood affective disorders. A. Major depressive disorder. An individual may get into a major depressive disorder either suddenly as a result of a major traumatic experience, or gradually over a period of several weeks or even months. The episode may last several months, and it is characterized by negative or depressed effect, i.e. low moods, low motivation, poor thought processes, and poor physical and motor functionings. This is where you find an individual have these modes which last several months, which is characterized by negative or depressed effects. You find this person is depressed, is very low with people, and they can't sustain relationship, is very cold. In other words, they have low moods, dull perceptions of the world. They are unable to engage, and they are unable to start or engage in any meaningful activity. They have no interest in any activity or in any person. These are people who, when they are with people, they have no interest in them, and they have no interest in any activity. They may have low appetite, but some may eat more. They lack interest in sex, experiences fatigue. They lack concentration on cognitive tasks. They lack confidence in themselves, and so they emphasize their weaknesses or failures rather than their successes. These are people, when they are with people, they look at themselves and they try to look on something negative and they measure on it. It is like somebody who had been in a relationship and they were affected in that relationship. So when they see other people in any relationship, they believe that that relationship is not going to work, and therefore to them, they cannot associate with persons of that same gender as the ones who hurt them. And they hawa ni wale watu wanakuwa extreme, and they hate people with passion, or they hate issues with passion. They are not motivated to engage in any activity. They have low self-concept and self-esteem, i.e., they feel less like and appreciated by others. They lack that worthlessness. These are those people that either they elevate their ego, or they put their ego down in such a way that they cannot relate well with people. Because they cannot relate to others, they feel guilty because they cannot relate to others. They feel guilty, and this makes them more depressed. Depression is related to physical illnesses in both directions, i.e., it can cause physical illness, while physical illness can cause depression. It can cause physical illness because it reduces immunity. Depression can result into substance abuse because the victim may resort to tranquilizers because of their anxiety or irritability. Depression has psychosocial and economical implications, i.e., the person loses friendship, relationships, and management of the condition has great economic ramifications. The person is not productive, etc. In the US, the prevalence is high, with between 8 to 20% of the population who will experience depressions in their lives. As society gets transformed, conditions for depressions increase. For example, the breakdown in cultural values, crime, poverty, and unemployment. The second thing or B is bipolar disorder, formerly manic depressive disorder. Bipolar disorder, or formerly manic depressive disorder. This reflects mood swings that are referred to as manic depressive. It refers to periods of depression preceded by periods of excitement or elated moods. The manic episode is characterized by 1. Elated mood or high excitement. 2. Believe that one has the abilities that can enable him or her accomplish everything. 3. The inability to focus on a single task. For such people, thoughts are rapid but unfocused. Activities are energetic but chaotic. People who display manic symptoms while under depressions are said to have a mixed episode. For instance, they may cry when elated and laugh when depressed. Some researchers believe that this mood incongruency is even more serious than mood congruent symptoms. there may exist a milder form of disturbance that DSM-4, Diagnostic Statistic Manual 4, refers to as hypomanic episode with the following symptoms. This is elated mood, little need for sleep, low tolerance for frustration, increased periods of activity, inability to complete the activities that one may have started with vigor. DSM-4 has identified 3 main bipolar disorders. So here there is the bipolar disorder 1, bipolar disorder 2, bipolar disorder 3. Bipolar disorder 1 or A. This is a situation in which an individual has one or more manic or mixed episodes, plus in some cases, one or more depressive episodes. This is where one has more than one symptoms of those manic symptoms or mixed episodes. Bipolar 2 involves major recurrent depressive episodes and at least one hypomanic episode. Then we have C, which is cyclothymic disorder. The one that I said bipolar 3, it is cyclothymic disorder. This is characterized by hypomanic symptoms followed by mild depressive symptoms over a period of at least 2 years. There may be periods of normal moods. So this is where you find somebody changes, but there are times when they have normal moods. Let's now get to psychotic disorders. We have schizophrenia. Schizophrenia. Definition of schizophrenia: most common psychotic disorder characterized by abnormalities in perception, beliefs, and thought processing. Epidemiology. Lifetime prevalence is about 1% in the general population. First onset is typically between 15 to 45 years, although men exhibit symptoms earlier than women. We have pathophysiology. Schizophrenia is associated with dopamine hyperactivity in mesolimbic context of the brain in basal ganglia. So when we talk of dopamine is when we are talking of the chemicals in the body which are associated with moods. When this chemical is in balance or has been deposited in mesolimbic context of the brain in basal ganglia, and they are just concentrated in just one particular area, they bring these conditions in that is called schizophrenia. Clinical features or positive symptoms. Here we have hallucinations, sensing things while awake that appear to be real but instead have been created by the mind. This is where somebody is seeing things that are not there, and they are not asleep, they are not unconscious, they are very conscious, but they are seeing things, they are hearing things that are not real, that are not there. Types of hallucinations. A, we have auditory hallucinations. This is hearing voices where no one has spoken. The most commonly type of hallucination, this is the most common of it, of the auditory hallucinations, where somebody hears things and nobody has spoken. And when these things comes to the church, this person may believe or may think that some angels or some God is speaking to them and they want people to believe in him. These voices may be many. These voices may be maybe someone commands someone to do something that may cause harm to themselves or to others. This is where somebody hears voices which tells them to commit suicide or to take a rope and to hang themselves. A voice may come and tell somebody to do something. Hearing sounds such as music, you find somebody just dancing alone or singing alone on the way and there is no music. Footsteps approaching, windows or doors banging. Then we have the other category of hallucinations is visual hallucinations. Seeing patterns, lights, beings or objects that are not there. You are with somebody but they are seeing things and you are not seeing them. And they are saying, I'm seeing highways, I'm seeing things coming, I'm seeing, and there is nothing that is coming. The third type of hallucinations is olfactory hallucinations. This is smelling a foul or pleasant odor. This is where somebody is with people but is smelling things that are very good or smelling very bad things, bad odor. Odors are smells that appear to be coming from specific or unknown place. Then the fourth type of hallucinations is tactile hallucinations. This is feeling bodily sensations such as a crawling feeling on the skin or the movement of internal organs. I don't know whether you've heard people saying that something is moving in their bodies. They are feeling something or they are seeing something moving in their bodies and they want you to believe that they are seeing it or they are feeling it and they are telling you it is here, it has come here, it is moving. This is olfactory hallucinations. Now this is tactile hallucinations. Then we have now delusional beliefs, very common, especially persecutory delusion. Ideas of reference are in which unrelated notices, signs or remarks are believed to be messages with specific meaning for the patient. So you find at times this person they believe that they have specific messages. Then we have thought insertion. Thought broadcast and thought withdrawal. Patient believes that other people know what they are thinking either because they can be heard or they are transmitted through TV or radio. So you find that those people with thought insertion where they believe that what they think people are also hearing or they are also thinking the same. And they believe that whatever is happening in them, some people are seeing it and they know them. There is a man who came some other times to the church and they asked me, do you know me? And I said no. He said, I've been advertised all over. I am in the news, I am in the media. And it was written even in the Bible that I will come. And I wondered who that person was. So I didn't know at that particular moment that he had this thought insertion. So the patients believe that other people know what they are thinking. And either because they can be heard or they are transmitted through TV or radio. Delusional beliefs very common, especially persecutory delusion. Ideas of reference are in which unrelated notices, signs or remarks are believed to be messages with specific meaning for the patient. So we have said that. Then there is the formal thought disorder. Individuals have difficulty in expressing their thoughts. They have loosening of associations, word salad, or neologism. Then they have experience of excitement or agitation, hostility or aggressive behavior, suicidal tendencies, suspiciousness or ideas of references. The negative symptoms. 1. Alogia. Alogia refers to difficulty with speaking. In some schizophrenic patients, alogia manifests as reduced total speech output and reduced verbal fluency, the ease with which words are chosen, Patients displaying alogia struggle to give brief answers to questions. When you ask them a question, they tend to give a brief answer. They don't ignore you, but they give a very brief answer, which is not detailed. We have associability. Impairment in social relationships, which include little interest in being with other people, poor social skills, and few friends. Avolition or apathy. Inability or lack of energy to engage in routine, e.g., poor grooming and personal hygiene. Here is where you find somebody does not take shower, does not take care of their personal hygiene. They are very poor in engagement in routine. They can't do that which is supposed to be done. Anhedonia. This is inability to feel pleasure. Inability to feel pleasure in anything. They can be taken to things that they so much want to have, but when they get there, they cannot get that pleasure. Others get that inability to get pleasure even in sex, in sports, in music. Lack of interest in or enjoyment in activities or relationships. Then affective blunting. This is decreased facial expression. Let's look at types of schizophrenia. Disorganized schizophrenia. This is a disorder characterized by incoherence, foolishness, and regressive behavior. Characterized by incoherent foolishness and regressive behavior. Somebody behaves in such a stupid manner which does not constitute their age and the place where they are. Then we have paranoid schizophrenia. This is a disorder characterized by delusions of persecution or grandeur. This is where somebody always feel like people are persecuting them, people are looking down on them, and they want to yani watu wanamkemea na wanataka tu kumaliza bila sababu. We have undifferentiated schizophrenia. This disorder is characterized by a variety of symptoms found in several of the types of schizophrenia, also called symbol schizophrenia. So this is like a combination of several types of symptoms in one person. They have hebephrenic schizophrenia. This is characterized by silly and childish behavior, prominent affective symptoms, and delusions common. We have residual schizophrenia. This is absence of prominent delusions, hallucinations, disorganized behavior with presence of old beliefs or negative symptoms. This is where somebody is seeing things which are not there, is hearing things that are not there, is very disorganized, he has a very disorganized behavior, and they have beliefs of negative symptoms. Everything they think is negative and nothing positive in them. Then we have catatonic schizophrenia. Catatonic schizophrenia is characterized by marked disturbance of motor behavior. That is, there is the disturbance in their psychomotor, in the behavior, the way they behave, may take the form of catatonic stupor, catatonic excitement, or alternating between stupor and excitement. Catatonic excitement presents with 1. Increased psychomotor activity, i.e. restlessness, agitation and excitement, increase in speech production, or loosening of association. Catatonic stupor presents with mutism, that is lack of speech. Rigidity, this is maintenance of posture against efforts to be moved. Then waxy flexibility, this is parts of the body can be placed in positions that will be maintained for long periods of time. This is where you can find maybe somebody is walking like this, is putting their hands like this while they are walking for some time, for quite a long period of time, and then there is a time when they put into normal. Or sometimes you can find them walking in a design that they maintain that design for a while, for a long period of time, and then they come back to normal. Stupor does not react to surrounding and appears to be unaware of them. So when you talk of stupor, is when somebody does not react to anything in the surrounding. You can go closer to where they are and you try to jaribu kuwashtua like this, ha! And they don't even hear like something is happening. Or they're just in a place where people are running for their lives and they're just staying and looking like stupid. They don't see that people are supposed to run for their lives. So they need someone to come and take them by force. Or they can even be walking and the car is coming and they are not even, it's like they are not looking at it and they are about to be knocked down. Schneider's first-rank symptoms of schizophrenia: auditory hallucinations, delusions of control, thought broadcasting, thought withdrawal, thought insertion, somatic passivity. This is bodily sensations are experienced as imposed on the body by external force. Made volition or acts. One-on acts are experienced as being under control of external force. Let's look at Bleuler's 4 A's of schizophrenia. Eugene Bleuler cited other symptoms called Bleuler 4A symptoms, which include autistic thinking. These are thought process in which individual is unable to relate with others or environment. Then ambivalence, contradictory or opposing emotions, desires for same person but feels bad about him or her. Associative looseness, this is inability to think logically. Affective disturbance, this is inability to show appropriate emotional response. Etiology, biochemical imbalances, overactivity, this is overactivity of dopamine within mesolimbic context. Then we have environmental factors, e.g. trauma during childhood, genetic causes, this is high prevalences relates in relatives of schizophrenic. So high prevalence rates in relatives of schizophrenic, which are genetic causes, then differential diagnosis, and mania, characterized by prominent affective features like grandiosity, overactivity, and liability of mood. Depression. This is chronic schizophrenia may mimic or coexist with depression. Then drug-induced psychosis present with hallucinations and delusions, and dementia presence within impairment in thinking. Medical management of schizophrenia. In the acute phase, older or type antipsychotics, e.g. Lagactil or haloperidol, have most effective on the positive symptoms of schizophrenia. Chlorpheniramine is more sedating, so these are the medications that are given to these particular persons. Patients may benefit from augmentation of antipsychotics with benzodiazepines, e.g. diazepam and lorazepam. Commonly used conventional antipsychotic drugs are, but don't prescribe this. You are supposed to take them to a psychiatric, and there is where these medications can be prescribed based on the test that will be done to this particular individual. So the commonly used conventional antipsychotics drugs are chlorpheniramine 300 to 1500 mg per day, or PO 50 to 100 mg per day, or 1 hour or IM. Then we have fluphenazine diconate 25 to 50 mg every month, or haloperidol 5 to 100 mg per day, PO 5 to 20 mg per day IM. Then commonly used atypical antipsychotics are clozapine 25 to 40 mg per day PO, risperidone 2 to 10 mg per day PO, olanzapine 10 to 20 mg per day PO, quetiapine 150 to 750 mg per day PO, ziprasidone 20 to 80 mg per day PO. Clozapine may cause agranulocorticosis, potentially fatal blood disorder marked by low white blood cell count and neurotrophil depletion. So clozapine is very effective that it can bring such an adverse effects of neurotrophil depletion, or it can bring that low white blood cells. Chronic phase. Depot antipsychotic injections, e.g. Modicate or flufenazine, may be used in patients with poor compliance. Use of newer antipsychotics, e.g. clozapine, olanzapine, and risperidone. 3-ECT is indicated for catatonic schizophrenia and severe depressive symptoms accompanying schizophrenia. Psychotherapy, counseling and advice to the patient. Behavior therapy, patient is taught appropriate behavior by direct instruction. Rehabilitation services to provide opportunities to increase skills in living, such as vocational rehabilitation. Then we have output treatment to provide aftercare, maintenance therapy, social support programs, and medical clinics. Nursing management. The first priority is to ensure safety of the patient and others. Remove all dangerous objects from the surrounding. You remove all dangerous objects. Protect the patient during acute episodes from absconding and suicide attempts. Administer prescribed antipsychotics and note the progressive and side effects. Provide less stimulating environment, e.g. dim light, less noise, and comfortable bed. Approach the patient with calmness, empathy, and gentle eye contact. Observe the patient behavior frequently and note any changes. Provide a structured environment with scheduled routine activities of daily living. Apply mechanical restraint safety if there is a justifiable need. Mechanism restraints applied too tightly may impair circulation. So when you are applying those mechanical restraints are something that you put on them to hinder their movement or to hinder them from doing any harm. So when you are applying these things, don't apply too tight, just loosen it so that they don't interfere with the blood circulation, because too tight may impair circulation. Assess the nature and severity of hallucinations. Distract the patient from delusions that tend to exacerbate aggressive or potentially violent episodes. Distraction can be done by engaging patient in constructive activities. Encourage the patient to express feelings as much as possible. Provide food and fluid to the patient to meet the physiological needs of the body. Provide assistance with self-care activities as required. Schizoid personality disorder present with delusions. Schizotypal personality disorder present with delusions. So obsessive compulsive disorders, OCD. Obsessive compulsive disorder. Patients experience and obsessions with involved thoughts, ideas, images that keeps recurring in one's mind, e.g. an individual may be obsessed by the feeling that his hand is dirty or he has not locked the door of his house or he has left something on fire. They also experience a compassion, which is an action. The person feels compelled to repeat again and again, even if the person has no desire to do so. Pathological obsession may tend to be recurrent day after day. Compulsions may involve either A. Those who are concerned with checking rituals, e.g. checking whether the cooker has been turned off, whether the door is locked, or the tendency to continuously check something like whether they have locked car doors. This is something that somebody from time to time they go and check. They feel like somebody else has not done it, and they want to check it every now. B. Cleaning rituals, e.g. continuously washing their hands. Obsessive compulsive disorders can be completely disabling because the individual is continuously involved in an obsessive and compulsive behavior, e.g. the inability to sleep because one feels he has not locked the room or that the room is contaminated with germs, thus he continuously sweeps, washes or fumigated the room. He keeps on fumigating the room because they feel that something in the house, something harmful is there. PTSD, post-traumatic stress disorder, develops through exposure to traumatic event, e.g. war, natural disasters, etc. Somatoform disorders. These are disorders in which psychological conflicts result in somatic or physiological or physical complaints. Some patients may report physical discomforts, e.g. stomach pain, breathing problems, etc. Others can show actual inability to physical function. They may fail to see or to swallow or move their legs or limbs without any organic evidence to explain these somatic problems. These disorders include 1. Conversion disorder. This is a disorder which is accompanied by pseudoneurological symptoms that affect sensory and motor function. Patients may complain of deafness, paralysis, blindness, seizures, and anesthesia or loss of feelings. 2. Hypochondriasis. This is a disorder characterized by obsessive health concerns. The victims are preoccupied with fear of disease and are constantly worried about being ill. The victims are usually disappointed when doctors refuse to confirm their self-diagnosis. They confine themselves to anxieties about more ordinary illnesses such as heart diseases, ulcers, cancers, etc. They usually focus on one illness or one disorder. 3. Somatization disorder. This is characterized by numerous and recurrent physical complaints that have persisted for several years. Although the individual tends to seek medical help, there is no medical basis for the symptoms. It is similar to a hypochondriasis to the extent that both involve symptoms with no evidence of physical cause. Hypochondriasis have a complaint of a specific disease, while somatization disorders have several complaints of a number of diseases. Hypochondriacs are bothered not by the symptoms, but because the symptoms indicate the presence of a disease. Somatization patients are concerned about the symptoms themselves. Hypochondriacs try to scientific to the extent that they can measure their blood pressure and report the results. They try to be clear about their symptoms as possible. Victims of somatization describe their symptoms in a vague and exaggerated ways. Hypochondriacs only fear one particular disease and therefore their complaints are fairly limited. In addition to distresses caused by imagined symptoms, victims of somatizations may develop genuine symptoms as a result of unnecessary hospitalization, medication, and surgery. Then we have body dysmorphic disorder. Victims are obsessed with post defects in their appearances, for instance, hair loss, skin blemishes, scars the shape of their nose, size of their breast, etc. These defects may be imaginary or exaggerated, but they make the victim self-conscious to the extent that they may interfere with the individual's social and occupational functions. As a result, people may even consider suicide as a way of getting out of this crisis. It usually begins in adolescence, where young people are particularly conscious about their appearance. It may be a basis of development of social phobia. We have anxious disorders. In anxious disorders, victims tend to wander from hospital to hospital complaining of an illness. Unlike malingerers who may pretend to be ill for a reason, factitious victims have no clear reason except attention seeking. They may wish to be either physically ill or psychologically disturbed. In both cases, the individuals may use drugs and other substances to enhance their symptoms. They appear quite knowledgeable about their medical conditions, and these presentations usually get them admitted until medical diagnosis proves them wrong. They therefore wander from one hospital to another because they may be forced out of these hospitals for lack of reasons to keep them admitted. These are people who try to look on something that can make them look ill so that they can be admitted in an hospital. I've heard of girls in the school. There is a time when we went for counseling in a certain school, girls' schools, and we found that girls are taking Omo, this powder soap, and they are putting it on water. Then they put those substances in their eyes so that the eyes become like they are sick and like it's gouging out so that they can be released to go home. And at times they are even admitted in the hospital simply because of something that they have done in themselves. We have dissociative disorders. Dissociative disorders involves the dissociation or splitting apart of the components of personality that are normally integrated. As a result, some psychological functions, i.e. identity, memory, control over motor functions, is no longer possible. Here we have psychogenic amnesia. This is memory loss where events that took place before a traumatic experience are forgotten. It may be one, localized amnesia, where events taking place during a particular period of time are locked out of memory, i.e. a person who survived an accident in which all his family perished may block out memory of that experience. 2. Selective amnesia. This is very rare and involves a person blocking out only spots or parts of the experience. An individual may remember the crash but may not remember seeing the bodies being taken away from the crash site. And 3. Generalized amnesia. The person forgets his entire past life. And 4. Continuous amnesia. The person forgets all events after a specific period and up to the present, including those events that occur after the onset of amnesia. Amnesia victims may not know who or where they are. They may not recognize family or friends. Those who like a particular type of food will continue to do so. Typists will continue to type. Drivers will continue to drive, but they have forgotten other things. Psychogenic fugue. This is a type of amnesia in which an individual leaves home and even adopts a new identity. This may wander around the town, go to the other towns, or even to other countries under a new identity. The duration may range from a few days to several years. It may range from a few days to several years, where somebody goes to a different place or even to a different country. They will appear fairly normal to the observers, but when they get out of the fugue state, they will be amnestic about the period of the fugue. Like amnesia, it occurs after a severe psychological trauma. We have the dissociate identity disorder. It is also known as multiple personality. The individual alternated between two or more distinct personalities, and each of the personalities has its own characteristics, such as tested habits, memories, and learned behaviors. It is rare and more complicated, especially as the number of personalities increase. Each of the personalities may take turns controlling the behavior and becoming unaware of the actions and thoughts of the others. There are times in which the subordinate personality is fully aware of the thoughts and actions of the dominant one. Eventually, they may become aware of each other, especially through their activities. In a two-personality pattern, they appear to be on opposite poles, thereby reflecting according to Freud, restraining on one side and self-indulgence on the other. We have depersonalization disorder. Here, personality is disrupted, but there is no amnesia. The main feature is depersonalization, where one feels something strange about himself or herself. Victims do not see themselves as real. Parts of their body may be seen as shrunk or grown or operating without their control. These extremists may be seen to be dead, i.e., the limbs. A sense of depersonalization may take place. The realization involved strange feelings about the world and other people. People feel unreal. It may take place in the course of normal life, especially when waking up from sleep. It can also be a component of other psychological disorders, especially anxiety, depression, and schizophrenia. Depersonalization is, however, considered as a disorder when it is severe and persistent enough to interfere with one's normal life. Let's now look at sexual dysfunction disorders. Sexual dysfunction disorders. Objectives. By the end of the lesson, the learner should be able to describe sexual response cycle, describe the types of sexual dysfunctional disorders, signs and symptoms, factors associated with each and the management. Then describe the psychosexual therapy. Let's get to sexual circle. Sexual response circle. So in the sexual response cycle, we have the desire phase. The desire phase is where the sexual urges occur in response to sexual cues or fantasies. This is where somebody looks at a woman or a man and then they desire to have sexual activities with them. So sexual urges occur in response to sexual cues or fantasies based on how you have looked at this particular person and you've perceived to be what the ideal thing, the ideal person have sex with. Then this takes us to arousal stage. Arousal stage is a subjective sense of sexual pleasure and physiological signs of sexual arousal. In males, penile tumescence, that is increased flow of blood into the penis. In female, vasocongestion, that is blood pools in the pelvic area, leading to vaginal lubrication, and breast tumescence, that is erect nipples. Then this leads to plateau phase. This is the brief period of time before orgasm. And after that, we get to orgasm phase, where in males, feelings of the inevitability of ejaculation, followed by ejaculation. In females, contractions of the walls of the lower third of the vagina. Then resolution phase. Here is the decrease in arousal occurs after orgasm, particularly in men, and it leads to the the phase begins all over again. The desire phase, the arousal phase, the plateau phase, the orgasm phase, and then the resolution phase. The resolution phase is where now people have, it has come to an end, and now the individuals maybe can now relax and think of something else, or they can desire to start it all over again. We have sexual dysfunction. This is characterized by a disturbance in sexual response cycle, or by pain associated with sexual intercourse, and cause marked distress and interpersonal difficulty. Here we are talking of sexual desire disorders, sexual arousal disorders, and orgasmic disorders. Sexual pain disorders. Diagnostic judgment here. It deals with age, culture, religion, and experience of the client, chronicity and frequency of the symptoms, subjective distress, and the effects on other areas of functioning. If sexual stimulation is inadequate in either focus, intensity, or duration, the diagnosis of sexual dysfunction involves excitement or orgasm is not met. So this is now the sexual desire disorders. We have sexual desire disorders. We have hypoactive sexual desire disorder. This is persistent or recurrent, deficient or absent sexual fantasies and desire for sexual activity. This is where there is that absence of persistent or recurrent deficient. The disturbance causes marked distress or interpersonal difficulty, and the sexual dysfunction is not better accounted for by another disorder and is not exclusively due to the direct physiological effect of a substance or a general medical condition. We have sexual aversion disorder. Persistent or extreme aversion to and avoidance of all or almost all genital sexual contact with a sexual contact. This is where a person does not want or avoids all or almost all of sexual act or sexual contact. They avoid it. The disturbance causes marked distress or interpersonal difficulty. The sexual dysfunction is not accounted for by another mental disorder except by another sexual dysfunction. Then we have sexual arousal disorder. Diagnostic or judgment. Here is age, culture, religion, and experience of the client, chronicity and frequency of the symptoms, subjective disturbance, distress, and the effects on other areas of functioning. If sexual stimulation is inadequate in either focus, intensity, or duration, the diagnosis of sexual dysfunction involving excitement or orgasm is not made. Here, this is the diagnostic of the sexual pain disorders. So in this sexual desire disorders, we have hypoactive sexual desire disorder. We are repeating the same. Now, in sexual arousal disorder, we have female sexual interest or arousal disorder, persistent or recurrent inability to attain or to maintain until completion of the sexual activity, inadequate lubrication or swelling response of sexual excitement. So this one is persistent or recurrent inability to attain or to maintain until completion of the sexual activity. The disorder may result in painful intercourse, sexual avoidance, and the disturbance of marital or sexual relationships. The disturbance causes marked distress or interpersonal difficulties. Then we have male erectile disorder. Male erectile disorder, persistent or recurrent inability to attain or to maintain until completion of the sexual activity and adequate erection. It is associated with sexual anxiety, fear of failure, concerns about sexual performance, and decreased subjective sense of sexual excitement and pleasure. The disturbance causes marked distress or interpersonal difficulty. This is where somebody fears that they may not do a good job, and therefore when they feel like or they are about to get or to engage into sexual activity, they cow down. Then we have orgasmic disorders. In female orgasmic disorders, persistent or recurring delay in or absence of orgasm following a normal sexual excitement phase. This is based on the age, sexual experience, and adequacy of sexual stimulation a woman receives. The disturbance causes marked distress or interpersonal difficulty, premature or early ejaculation disorder, persistent or recurrent ejaculation with minimal sexual stimulation before, on, or shortly after penetration and before the person wishes it. Psychological factors, newly married, fear about performance, stressful relationship, etc. And physical factors, some men may be tactile sensitive, responding more intensely to stimulation. Genitopelvic pain penetration disorder. Dyspareunia, or not due to general medical condition. Recurrent or persistent pain associated with sexual intercourse in either male or female. Vaginism, not due to general medical condition. This is recurrent or persistent involuntary spasm of the musculature of the outer third of the vagina that interferes with sexual intercourse. That is recurrent or persistent involuntary spasm of the musculature of the outer third of the vagina that interferes with sexual intercourse. The general treatment of this, the medication is that hormone shots, pills or creams. Others use Viagra, mechanical aids, penile implants or dilators, sex therapy, behavioral treatments, avoid smoking, drinking or drug use, psychotherapy, manage stress, anxiety and concerns, education and communication about sex and sexual behaviors, create an open dialogue about sex and sex behaviors, management of sexual dysfunction disorders. We have the following criteria for assessment. The following are some of the factors to be covered during the assessment interview. Adopt anal-explicit model. The nature and development of the sexual problem. family attitudes towards sexuality, that is the taboo elements that are associated with sexual activities. It needs to be understood or dug out. Sexual knowledge, how and from where was it gained? How did this person, particular people, got this message about the sexual activity? Gender identity and role. Do the individual feel safe with the gender identity or role during childhood or adolescent? Then puberty. When did this occur? Was it early or late compared with peers? Was it traumatic for the female? Ask about the onset and early understanding of menstruation and subsequent patterns. Masturbation. If it occurred, was it associated with guilt? Does the individual masturbate now? Inquire about masturbatory fantasies. Interest in opposite sex. When did it develop and what was the nature of the first heterosexual relationship? Homosexuality. Any early homosexuality, but more importantly, is there any current homosexual interest? Try to dig deep to look whether there are these forms of homosexuality that has occurred. It has been said that a man who has engaged in homosexuality finds it difficult to maintain a relationship, especially in sex relationship with a woman, simply because when they use the homosexual way, the anus was not made for the penile penetration, and therefore the anus is very hard. It lacks that mechanism to hold the penile penetration, and therefore when a person enters into the vagina, it becomes hard because there is lack of that grip. Relationships and sexual contacts prior to meeting the current partner. Have there been partners? Has sexual activity occurred in these relationships? And if so, were there problems? Then look at current relationships. When did the couple meet? What attracted them to each other and how did the relationship develop? Is there any general discord in the relationship of which sexual difficulty may be merely a symptom? If so, general marital therapy might be indicated. Has the sexual problem undermined general relationships? Then how did the current sexual relationship develop? Was there a problem initially or it suddenly appeared? Are there any physical, e.g. diabetes, neurological diseases, pelvic pathology, medicines, or psychiatric factors, that is such as mood and anxiety disorders, that could account for the problem? The physical examination, if indicated to exclude organic causes of the dysfunction. Therapeutic intervention. The treatment of sexual dysfunctions altered drastically following Masters and Jones' work in 1970. Until then, more attempts at RX had involved lengthy psychoanalysis or psychotherapy of an individual, producing only fair outcomes. Principles of Masters and Johnson approach. The couples are helped to communicate both verbally and non-verbally about and during sexual behavior. Education is provided concerning sexual anatomy and physiology. The couple should concentrate on the uninhibited giving and receiving of sexual stimulation and allow spontaneous physiological reactions, e.g. erections, orgasm, to take care of themselves. The give to get principle, i.e. partners encouraged to give pleasure to receive it. Couples are engaged in a very intensive program of 2 to 3 weeks in which the couple is encouraged to carry out a graduated series of homework assignment aimed at establishing a rewarding sexual relationship. Therapists work in pairs, one male and one female. Plan of the plan of psychotherapy, psychosexual therapy. Formulation. The couple together is given an explanation of their sexual difficulty in terms of past causes and current factors serving to perpetuate the problems. Agreed ban on sexual intercourse and intimate touching in the early stage of treatment. Instead, the couple engages in sensate focus. Here, they involves exploring of each other's bodies in order to give and receive pleasurable sensation, with emphasis on communication and giving pleasure in order to receive it. Genital sensate focus. The couples move to involve the genital and breast areas in their caressing and exploration. Education. A very important part of therapy which involves providing information on sexual physiology and anatomy and how to engage in effective sexual stimulation. Visual aids are often helpful. Specific techniques may be used aimed at correcting specific problems, e.g. the squeeze technique for premature ejaculation or the use of graded dilators for vaginisms. Education, a very important part of therapy which involves providing information on sexual physiology, anatomy, and how to engage in effective sexual stimulation. Visual aids are often helpful. Specific techniques may be used aimed at correcting specific problems, then gradual return to sexual intercourse. This one occurs usually through an intermediate stage of vaginal containment with no movement using the female superior or lateral positions. These positions are encouraged because they facilitate continuing use of such techniques as the squeeze and may be effective stimulants of the female partner. Biological treatment, we have the Viagra or sildenafil, Cialis. Let's look at sexual disorders. 1. Paraphilias. Paraphilias are recurrent and intense sexual urges or sexually arousing fantasies involving non-human objects, children, or consenting adults. Types of paraphilias. 1. Frotteurism. Recurrent and intense sexual urges to touch and rub against non-consenting adults. Common in men who rub their genitals against non-consenting women, especially when getting into and out of a car. They can also rub their thighs and breast and achieve maximum satisfaction by doing so. These are people who, when they look at a woman, they just want to feel that touch, and then there they go. We have number 2, voyeurism. Recurrent and strong sexual desire to observe and suspecting people in secret as they undress or to spy on couples engaged in intercourse. The people normally go near bedrooms at the outside of rooms and listen to the ongoing act and if possible watch it. 3. Exhibitionism. This is recurrent sexually arousing fantasies or urges of exposing genitals or male to another person. Their sexual relationships with their spouse are not satisfactory because they just exposed to them without engaging them in act. So this is where they want to show their genitals to. It is like a show of their genitals. Then we have 4. Fetishism. Recurrent intense sexual urges, sexually arousing fantasies or behaviors that involve use of non-living objects. Fetish objects include women underwear, especially with bright colors such as pink, shoes and boots. The objects are worn, touched or smelled, and the person achieves satisfaction. This is where a person takes a woman inner clothing and they smell it and then they reach orgasm. Then we have pedophilia. This is sexual satisfaction is obtained by watching, touching, or engaging sexual act with prepubescent children under 13 years. This is where somebody touches a child and they achieve orgasm. We have sexual masochism. pattern in which a person has intense sexual urges and fantasies that involve being humiliated, beaten, bound, or made to suffer. This is where somebody achieves sex by being beaten, or when they are under that act, they love being beaten, being slapped, they love being, yani wanataka kugongwa, kupatiwa kapain hivi. Sasa kwao ndio ni kama wanasikia kwamba wanafanya kitu. Yeah. This is where it involves being humiliated, beaten, bound, or made to suffer. They request their partner to restrain, to tie up, whip, or electrically shock them to achieve sexual satisfaction. Then we have the last one is sexual sadism. This is a pattern in which a person, usually male, is intensely sexually aroused by act of inflicting pain to others. They can cut or even strangle others. Hii ni kama mtu anataka kuua mtu akifanya mapenzi. Then we have so those are the things that happens to these personalities, and as we look down, we say that there are things that also comes with these disorders, and we say that we have personality because it all comes from personality, especially when talk of abnormality or abnormal psychology, we are talking of the personalities that come with the individuals. And very briefly or very quickly, we are just going to do a replica of the personality disorders that normally comes in, because you cannot talk about these disorders without talking of personality disorders. And personality traits are enduring patterns of perceiving, relating to, and thinking about the environment and oneself, and are exhibited in a wide range of important social and personal contexts. If traits are not flexible, and if they are maladaptive in such a way that they cause significant functioning impairment or subjective distress, then they constitute personality disorders. Unlike disorders such as anxiety, somatoform, and dissociate disorders, which appear at any time of one's life, personality disorders usually start in childhood or adolescence. They are long-standing habits of thoughts and behavior. Personality disorders may give less pain to the people who display them, those who deal with the victims, such as co-workers, patients, parents, or children in the family, etc. Let's look at the personality disorders. We have one, paranoid personality disorders. This is characterized by suspiciousness in almost all situations and with almost all people, usually for very flimsy reasons. If informed or confronted with info that his or her suspicions are baseless, the victims continue to mistrust whoever who has said that he or she is wrong. It reflects a breakdown in cognitive functioning, i.e., the thinking and reasoning ability of the individual has collapsed. Paranoid people are constantly looking for and providing evidence for these suspicions. The behavior usually impairs emotional adjustment, and the victims usually have very few friends because they trust nobody. They may have people whom they can trust, but eventually they may lose trust for such people and move on to other people. The disorder is not disabling, and loss of reality contact is still minimal. Number 2, we have avoidant personality. Avoidant personality is characterized by social withdrawal, not because they are unable to experience social warmth, but because of fear of rejection, humiliation, or shame. They want to be loved and accepted, but feel that they are not accepted of being loved and accepted. They tend to avoid relationships unless they are assured time and time again of the other person's uncritical acceptance. Even when they remain watchful of any sign of disapproval, avoidant personality feels emotional disasters if he waits too long for a friend to arrive. If he waits too long for a friend to arrive, the lateness is proof that the friend no longer cares. They therefore no longer care. They feel depressed and angry at themselves for their social failures. This in turn erodes their self-esteem further. The third category is dependent personality disorder. This is also characterized by low self-esteem, and the individual is dependent on others. They are fearful or incapable of making their own decisions, and therefore turn to least one or two people to make these decisions for them. Fear of being abandoned, especially for women, will make them endure their husbands' misbehaviors, which include infidelity, physical abuse, etc. A vicious cycle may result, for instance, the more a dependent person lets others control or abuse him or her, the more he or she will feel helpless and stupid, and these feelings in turn discourage the person from being assertive. Number 4, borderline personality disorder, BPD, borderline personality disorder. This is characterized by instability. The victims are unpredictable in their behaviors. They may lead a quiet life at one stage but suddenly shift to a hectic, exciting life at another stage. Emotions too many shift between outbreaks, anger, and spells of depression, emptiness, or boredom. Relationship tends to be up and down. There may be a severe intensity or career choice and prone to boredom. Number 5, histrionic personality disorder. Histrionic personality disorder is characterized by exaggerated display of emotion with the intention of attracting or manipulating attention or sympathy from others. This type of people may faint at the sight of blood. The person may be so overcome with emotion after a movie that he or she may have to be taken home immediately, thereby spoiling the other person's evening. The individual may threaten suicide if the lover's interest cools down. Interpersonal relationships are usually fragile in the beginning, and they may seem warm and affectionate in a relationship. However, this deteriorates to a point when they become too expressively demanding in times of emotional crisis. Number 6, we have narcissistic personality disorders. This is characterized by a grandiose sense of self-importance, often combined with periodic feelings of inferiority. Victims tend to brag about their achievements and talents and may predict great success in certain activities. They display a sense of self-love. They may also display very fragile self-esteem, such that they keep checking how they are regarded by others. If criticized, they react with anger, although they demand a lot from others in the form of affection to show a tickling lack of sympathy. Friendships tend to be erratic. Then, with number 7, we have obsessive compulsive personality disorder. This should not be confused with obsessive compulsive disorder. It is characterized by excessive preoccupation taken up by mechanisms of efficiency, such as organizing, following rules, making lists and schedules. The efficiency is undermined because they never get anything done. They are stiff or rigid and informal in their dealings with others, and therefore cannot take pleasure in anything. They never deviate from their itinerary or schedule, and since they plan for others, they are not good company. Their preoccupation with trivial arrangements make them less efficient because most of the time is spent organizing themselves. And then we go to antisocial personality disorder. This is a chronic differences to and violation of the rights of one's fellow human beings. It involves criminal behavior mainly among male youths in their 20s, and it is characterized by a history of illegal or social disapproved activity beginning before age 15 years and continuing into adulthood by puberty, So by puberty, such activities will be in the form of truancy, delinquency, theft, vandalism, lying, drug abuse, running away from home, or chronic misbehavior in school. In adulthood, it could be in the form of prostitution, pimping, drug selling, and other crimes, e.g. gambling. Failure to show constancy or consistency and responsibility in work, sexual relationships, parenthood or financial obligations. They tend to walk out of jobs, spouses, children, and creditors. Irritability and aggressiveness, i.e., they are easily irritated and express their anger not just in street brawls but also in abusing spouses and children. Reckless and impulsive behavior. They operate without plans and they have no goals in mind. They seek thrills, travel from town to town with no goal in mind, and sleep around and steal whenever convenient or gratifying. They have disregard for the truth. They lie frequently and easily. So we've come to the end of our today's lesson or today's course on abnormal psychology. So you need to go and do much study about the same if you want to go further and to do deeper and deeper. Thank you so much. We are once again Christian Leadership of Minnesota and beyond, KITENGELA campus, the School of Counseling Psychology. Thank you so much.